Hi, and welcome back to the WHY-O-MYO podcast. This is Janine Steen, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. So, what can you do to identify a patient with a tongue thrust before even seeing them, looking in their mouth, or hearing them speak? So the very first way, and I spent some time or a lot of time doing this, is through their history or through their case history, background history. And even prior to seeing a patient, that history is going to point me in a direction. For example, if the child was breastfed, however, it was painful and mom could only do it for a short time, the child wasn't gaining weight, the child has a history of strep throat and throat type infections. They also have a difficult time saying letters, sounds for S as in Sam and Z as in zebra. The child is reported to be a restless sleeper, kicks his covers off in bed, maybe breathes heavy at night, and mom reports a really limited diet. So before even seeing the child, just hearing that history, it tells me that with a history of throat or strep infections, that this child either is presenting with enlarged tonsils presently or has in the past, especially in the situation where it's a chronic issue. With a chronic strep throat issue or chronic throat infection issue, even a chronic issue with congestion, allergies, etc., we often will see that the tonsils are consistently enlarged, or the adenoids are consistently enlarged, or they vary in size based on the time that they are symptomatic. So if the issue is a chronic one, we can assume that those tonsils and adenoids never shrink back to size. We can assume that, we don't know. So we could also assume that they could potentially have enlarged tonsils at the time of their evaluation. The other thing is we can listen to the types of sounds they're having difficulty with, which always goes hand in hand with the tongue thrust. The symptoms of what happens when they're asleep, those point us to some sort of maybe a sleep disturbance or some interruption or blockage of the airway. And even talking about mom's painful breastfeeding and difficulty gaining weight, that could point us to a short frenum, labial, lingual, or both. Once the patient or your child comes into your room and you are able to see them, again, before even having them speak or open their mouth, you can tell by the way they look that they are potentially a candidate for myofunctional therapy and present with a tongue thrust. So at this moment, if you're not driving, I want you to close your eyes for a second as I categorize or describe a patient to you, and tell me if you can see that patient in your mind. So first and foremost, remembering that this patient is one that has the history that I just reported. And now the patient walks into the room, they don't say anything, and I just look at them. So when I look at them, their mouth is open, their lips look swollen, they're definitely chapped. Their upper lip appears to be being pulled backwards towards the philtrum, or that space under the nose. The lips definitely seem swollen, but it also seems that it's a little bit of a challenge for the patient to keep their lips closed. So habitually is sitting with an open mouth posture and potentially breathing through their nose. Breathing through their mouth and not through their nose. The other visual is I can see these dark circles under the eyes, and the whole face seems like it's hanging, just kind of droopy. The eyes look wide but tired, and they have these dark circles under their eyes that are pretty significant. When I touch their nares and I hold one side and have them breathe in and vice versa, I can tell that they're congested, or I can see that they're congested, which again is further supporting that open mouth posture or mouth breathing. Once they open their mouth, I can look at their palate and I can see that the palate is high and narrow. It actually looks like the shape of a thumb, as well as the upper central incisors appear to be tilting outwards towards the upper lip, and there is minimal alignment between the top and bottom teeth, with a lot of jaw sliding and instability. When I ask this patient to swallow, I can see that there's tension in their neck. They shrug their shoulders and tuck their chin when preparing to swallow and during each swallow. And when I observe the oral cavity after, there is scattered food throughout, stuck in the cheeks, in the teeth, on the tongue, even some on the lips. Then I ask the patient to open their mouth and click their tongue, and their frenum is short. It is creating a dimple at the tip of their tongue, and their tongue actually looks like the tip is in the shape of a heart. There's spacing between the upper central incisors, which is caused by the labial frenum being short. And when I look towards the posterior portion of their oral cavity, I can see that the tonsils are enlarged, and both the right and left tonsil are touching the uvula, although there is a small space of airway still visible. Last and final, I feel the patient's cheeks, and when they're opening and closing their mouth, I can feel the jaw shifting from side to side. I can feel some clicking or popping as they open and close their mouth. And I can definitely also feel that they are not engaging the muscles in their cheeks, their masseter muscles, and appear to be stressing, and I should even say overstressing, the mentalis muscle in the chin, thus making it well defined, and it looks like a fingernail was pushed into the chin, causing an indentation. Did that help to give you a visual? Based on that vision, or what I was able to observe, it pointed me in the direction of a tongue thrust and the need for myofunctional therapy and potentially a frenectomy or an oral surgeon referral, a potential orthodontist referral, a potential ENT referral, and what looks like a tongue thrust. So now, as I finish my observation piece, I ask the child to speak. And anytime there is a word with the L as in Larry sound in it, you can see their tongue coming forward. As I engage them in conversation, I can see the tongue coming forward more often than it should, remembering that we should only see the tongue for the TH sound. The TH is in thumb, or TH is in bath or bathe. That's the only time you should see the tongue. So if you're seeing that tongue during the production of other sounds, then it is pointing in the direction that they are thrusting and the tongue is too far forward. I then can also assess if there's any other sounds that are being misarticulated or interdentalized or lateralized, and I am able to make a note that it does seem like all lingual alveolars are being thrusted forward, and most often I see an interdental lisp, but at times I can see a bilateral lisp or a unilateral lisp, depending on the sound. I can also tell from in conversation that it's not just the L sound that is being produced too far forward. I do see it with the T sound, the D sound, T as in Thomas, D as in David, N as in Nancy sound as well. Again, remembering that these sounds are never misarticulated, they're just distorted, meaning they're not saying the G sound for G as in go, for the D sound as in David. They are actually, the D sounds just like it should, however, its placement is not correct, whether it be too far forward or incidentalized. The other thing that I notice when I'm having them speak is that they tend to express some saliva while speaking, also saliva pools in the corners of their lips. And anytime they need to swallow, they actually have to stop mid-sentence and swallow, or else they will just pool saliva or spit saliva when they're speaking. Last and not least, I'm listening to their resonance pattern, their intonation, prosody, as submucous clefts are often misdiagnosed, and oftentimes they're diagnosed as a tongue thrust, but yet they're actually not a tongue thrust, and they do present with very similar symptoms. It also will speak to us about just their resonance as a whole. If it's not the result of a submucous cleft, is it the result of congestion, enlarged turbinates, deviated septum, something that's blocking the airway, that's making them sound more hyponasal? And then at that point, determining if that issue is more a motor planning issue or is it something that is structural in nature. So without actually giving a formalized assessment or even assessing for a tongue thrust, the case history and my observations was able to identify those areas right off the bat. However, it is then important to move forward with the myofunctional therapy evaluation, as well as any articulation or motor planning evaluations as well, in order to have something that's also substantiating what's happening and the problems that they're having, but also so that we can gauge success across all venues and have a barometer in terms of the standards that we're setting and the goals that we want to achieve. I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.